This is a quick summary of the NHS long-term plan, which was published in January of 2019. The plan sets out key ambitions for the NHS over the next 10 years. For nearly a decade, the NHS has experienced a significant slowdown in funding growth, while demand for services and the cost of delivering those services has grown rapidly. Cuts to public health and social care funding have added further pressure. As a result, the NHS performance has declined. Key waiting time targets are being consistently missed, and the finances of the NHS are being severely challenged. At the end of 2017-18, the NHS was overspent by approximately £1 billion. We're also facing workforce shortages, and these are widespread, with more than 100,000 whole-time equivalent staff vacancies in hospitals, including more than 40,000 nurse vacancies. Last year's winter crisis, the effects of which are still being felt well into the summer, underline the fragile state of the service. In June 2018, the Prime Minister announced a new 5-year funding settlement for the NHS. This meant a 3.4% average real terms annual increase in NHS funding between 2019 and 2023. This equates to £20.5 billion per year by 2023. This compared to growth of 1 to 2% per year in the previous decade. To unlock this funding, NHS England was asked to develop a long-term plan for the service. The new service model aims to boost out-of-hospital care and remove the historic divide between primary and community care. New funding would be linked to helping general practice meet the increasing demand and expand other local services to support communities. Digital will also play an important role in transforming outpatients, as well as offering different services to patients in general practice. Within 5 years, all patients will be offered online digital consultations with a GP. The NHS plan commits to investing more in primary and community care, and that the rate of investment will grow faster than in other parts of the NHS. By 2023-24, this commitment will guarantee an investment of at least £4.5 billion, which will be ring-fenced for primary and community care. This investment will guarantee that it will fund expanding the workforce, addressing some of the demand pressures that both community and general practice face, and also develop new services that will meet relevant goals that are set out in the long-term plan. The long-term plan sets out a number of clinical priority areas, and these include cancer, cardiovascular disease, maternity and neonatal health, mental health, stroke, diabetes and respiratory care, and there is also a strong focus on children and young people's health. If we look at cancer, the aim is to improve survival by making the diagnosis earlier. Currently, only about 54% of cancers are diagnosed at stage 1 or 2 of the disease. By 2028, the aim is to diagnose 75% of cancers at stage 1 or 2, and this will mean an additional 55,000 people per year will survive their cancers. The plan also sets out a number of actions to improve the detection and care for people with cardiovascular disease, respiratory disease, to prevent diabetes, to improve stroke services, and the aim is to prevent up to 150,000 cases of heart attack, stroke, and dementia over the next 10 years. So what does all this mean for primary care? General practice remains the foundation stone and building block of the NHS. Removing the historic divide between primary and community care means that district nursing teams will be configured around the footprint of a primary care network and work with practices, creating a single team to look after their community. And in an ideal world, district nurses should be co-located with practices and use the same clinical record. Primary care will be receiving additional funding to the tune of £2.8 billion by 2023-24 to expand the workforce by 20,000 staff. And these will be typically social prescribers, clinical pharmacists, physicians associates, first point of contact musculoskeletal practitioners, and paramedics. The additional 1.7 billion, which will make this up to 4.5 billion, which has been committed for primary and community care, will expand the community and mental health teams who work with general practice in the communities. Also, there'll be integrated care teams, which will be widely available to support general practice, especially for the patients with complex problems. A primary care network is made up of member practices who are geographically contiguous and would normally form a community of between 30 to 50,000 people. As part of the additional funds delivered through the GP contract, practices are incentivised to work together and will receive additional funding via the primary care network for new staff. Funding is also made available for a clinical director in each primary care network who will normally work 1 to 2 sessions a week. Over the next couple of years, some existing services such as community teams and mental health as well as social care will be required to configure their teams to work in an integrated way with primary care networks. The expectation is that primary care networks will become a delivery unit and will receive additional funding to deliver other services either alone or in partnership with other providers. An integrated care system brings together local organisations to redesign care and improve population health, creating shared leadership and action. They're a pragmatic and practical way of delivering the triple integration of primary and specialist care, physical and mental health services, and health with social care. Every ICS will need streamlined commissioning arrangements to enable a single set of commissioning decisions at system level. This will typically involve a single CCG for each ICS area. CCGs will become leaner, more strategic organisations that support providers to partner with local government and other community organisations on population health, service redesign, and long-term plan implementation. In summary, the long-term plan focuses on population health rather than activity. Choice and competition is replaced by provider partnerships. That's acute, community, general practice, and the local authority working collaboratively together. Additional money has been agreed on the basis of service redesign, but also on specific patient improved outcome measures. Also for general practice, this removes the historic divide between primary and community care.